I've had the opportunity to work with Tear Lab back in the day, all the way to now where it's reinvigorated company called Trukera. I was an early adopter and a believer in doing objective testing in order to make the proper diagnosis and monitor the treatment effects that I was proposing to my patients. Patients loved having numbers that they could follow, and Trukera now, focused on corneal health, we will be able to deliver precise, accurate diagnostics in the arena of corneal health. It is no longer the era of kind of eyeballing where our refractive outcome is going to be. That era is long past, especially with the availability of the different advanced technology IOLs, whether it's to correct astigmatism or presbyopia. We need to get as close as possible to our refractive goal. And if we don't, there are a lot of consequences. Not only a bad reputation, not only 1 star instead of 5, but it really gobbles up chair time, which none of us really has to offer. Therefore, prepping the ocular surface, tuning up the tear film, stabilizing it ahead of time, then doing the pre-surgical measurements will yield more accurate data because we're taking reliable numbers and plugging them into whatever formula each doctor wishes to use. As a result, we will get closer to our refractive goal and keep those patients very happy. I was very fortunate to be one of the investigators and co-authors of the study that was published in Cornea some years ago, looking at osmolarity and the importance of it in terms of IOL power calculation and astigmatism. In our study, the lead author was Alice Epitropoulos. We noticed that 1 out of 5 patients who were hyperosmolar, in other words, patients who had normal osmolarity, which in the study was 308 and below, their in-between Ks remained the same, very little variability between 0.25 and 0.5 diopter between visit 1 and visit 2, about 2 weeks apart. Whether those patients who started with a hyperosmolar number, 308 and higher, between the 2 visits demonstrated tremendous variability in their Ks, and as I was alluding to just a few seconds ago, 1 out of 5 patients had between 1 and 3.5 diopters of difference between 2 visits, 2 weeks apart, with no interval treatment. As a result, if your patients are hyperosmolar, A, how do you know? And B, how are you capturing the data that's reliable because of that inter-visit variability? Therefore, stabilizing the tear film, getting that consistent number that we all need will deliver no refractive surprises. Even though we know how important tear osmolarity is, there in the past was some pushback about the large real estate that the early tear lab devices occupied, how long it took to get the data. With a new version, the ScoutPro, we can get measurements in 40 seconds for 2 eyes. Moreover, there is no landing spot for this device. It can be kept in the pocket of a technician, therefore easy access to pull out of the pocket, do the test, get the tear osmolarity data in 40 seconds, and move on. Therefore, the pass-through of the patient is not impacted. There's no delay, and there's no real estate that has to be devoted to a large clunky machine. We're so fortunate that we have so many excellent astigmatism correcting and presbyopia correcting IOLs on the market right now. Back in the day, these didn't exist, or for a while we only had an option of 1 or 2. Now, actually, we have dozens of these incredible implants. As a result, patients are expecting almost unrealistic visual outcomes after cataract surgery. They're paying out of pocket. They understand that maybe some of their friends or family members have achieved incredible vision. However, it all starts with a tear film. After all, it's 2/3 of the refractive power of the eye. So we need to stabilize it. Once the tear film is stable and healthy, or as healthy as we could get it, do the measurements in order to confidently utilize these advanced technology implants, offer them to our patients to improve their quality of life for the rest of their lives.